Good afternoon and welcome. My name is Sarah Norman from NeighborWorks America, and I'm happy to welcome you to a webinar on best practices and resources to help older Americans to age in their homes and communities. This webinar will have three parts. The first is a presentation from Leah Lozier of HUD, U.S. Department of Housing and Urban Development. She's going to be presenting a new funding opportunity around helping folks to age in their communities, in their homes. Then we're going to take questions from her and really focus on that. We're going to take a break and then switch to a presentation from two executive directors about SASH, Support and Services in Home, and they're going to present on that. And then there's going to be an opportunity to ask questions of that. And then we're going to switch into a third gear, and we'll open the lines at that point and allow for a discussion of anybody who wants to sort of exchange ideas or questions, and it'll be that final portion will really focus on the network only and folks to sort of do some exchange of information, potentially going from there. So with that, again, I'm coming here from NeighborWorks America. I started about 2 years ago to think about how NeighborWorks could better support its organizations working at the intersection of health and community development. Most recent, we did a strategic assessment. We've been doing a lot of different webinars and learning communities and courses and a lot of different things, but most recently we offered a round of grants in partnership with the Robert Wood Johnson Foundation that are available for NeighborWorks network organizations, and so if you haven't seen an announcement of that, you can go to the NeighborWorks member site and see that. But really trying to provide a broad range of support to help groups to think about how they can support the work they're doing in their communities to build healthier communities. So with that, again, the agenda, we're going to open with Leah Lozier from the U.S. Department of Housing and Urban Development. She's going to share a notice of funding opportunity that relates to aging in place. There'll be questions and answers for her. Folks who have sent in questions, in advance, we've already shared that with our presenters, but you can ask additional ones, things that are prompted by the presentation, things that you just thought about. After that, we'll switch to a focus on a specific program called SASH that's working in Vermont. Tricia Ingalls from Rural Edge and Eileen Peltier from Downstreet Housing and Community Development will explain sort of how they operate, how they function, and it does have a tie-in to the previous presentation in that some of the lessons learned from this SASH did inform HUD as they were thinking about designing their funding opportunity. Of course, there's a lot of other sort of inspirations for the funding opportunity as well, but we thought it would be a way to sort of see a lot of different resources and opportunities to think about helping to older Americans to age in their homes to bring this together. So with that, I'm delighted to turn this over to Leah Lozier of the U.S. Department of Housing and Urban Development. Leah, it's all you.
Thank you. Thank you so much for having me. Can you hear me okay?
Yeah, it's fantastic.
Okay, great. I just want to make sure the connection is good. So I'm going to spend about the next 20 minutes or so talking about our NOFA, and this is the Supportive Services Demonstration for Elderly Households in HUD-assisted multifamily housing. So a bit of a mouthful. Next slide, please. So what do we have here? We have approximately $15 million under the FY 2014 Consolidated Appropriations Act for this NOFA, and really what we're looking is to test a model of aging in place, and we are restricting this demonstration to HUD-assisted multifamily properties that are elderly designated and have at least 50 assisted units. So let me go a little bit more into the nitty-gritty of the demonstration. We can go the next two slides, actually. All right. So what are we doing here? Since 2010, we've been building an evidence base to develop a strong demonstration and publish a NOFA that's really unlike anything we've done before. As I said, our main goal here is to test a housing with services model to support aging in place. And within that framework, we designed a model intended to, 1, delay or avoid the need for nursing home care, and 2, have positive impacts on resident health and well-being. So what exactly are we funding here? Next slide. The NOFA will fund a supportive services model explicitly designed to support aging in place. And so as you'll see in the NOFA, it's actually section 1A1C, if anybody wants to go look. HUD is funding an enhanced service coordinator and wellness nurse to work on site at the property as an interdisciplinary team. They'll assess residents' social and health services need, needs, connect them with available community-based and health services, and liaise with providers. You may be familiar with the HUD Service Coordinator program. This is similar but much more robust and really designed to more fully address aging residents' needs. Importantly, we're not just providing funds to hire an enhanced service coordinator and wellness nurse. HUD will also be providing training, resources, and technical assistance so this program runs as smoothly as possible for residents, the staff, enhanced service coordinators and wellness nurses, and the applicants. So we're looking for people that have never done anything like this before. In part, it's really part of it is helping property owners who've never had a service coordinator, nurse, or similar program. We want people to apply. And if you or someone you know or the properties already have a service coordinator, maybe through the HUD Service Coordinator Grant Program, we want them to apply too. This NOFA will provide funds to bring a current service coordinator up to our enhanced level and hire a wellness nurse. Next slide. You may be wondering what this interdisciplinary team will actually be doing at the property. We're fine-tuning the details with outside experts, but we've really identified some core components of the model based on our previous research experts. There's a lot more detail in the NOFA, but the enhanced service coordinator and wellness nurse team are going to be expected to do things like coordination and support of transitions from a hospital nursing home back to the property, assistance with medication self-management, falls prevention programs, mental health programs, and engagement with healthcare providers. A really important aspect of this is that we will also be developing partnerships with service providers to help provide residents with more seamless care and coverage across multiple social welfare and health domains. But remember, we're going to have extensive training and technical assistance for all of this. So if you're listening in on behalf of applicants, they will not be expected to stand up a program like this alone. Next slide. An important piece of this demonstration is not just implementing a new supportive services model, but also setting the program up so it can be rigorously evaluated and we can measure its impacts. This should be of interest to everybody who has a stake in helping seniors age in place. We have to be able to credibly make the case that these programs are necessary and valuable, and the absolute best way to do this is through a randomized control trial. And really, it's the only way to reliably know if the supportive services model is causing impacts on health and well-being. So what does this entail? First, the creation of treatment and control groups. The treatment group is a group of applicants that will be standing up the supportive services model I described earlier, and the control group will be continuing doing business as usual. If they have a service coordinator, keep that program going. If they don't, just continue to serve residents however they've been doing it. It's important to remember we have to be able to compare the treatment group against something, which is why we need a control group in the first place. And that brings us to the lottery. The fairest and most sound approach from a research perspective is using a lottery, also known as random assignment, to place eligible properties in these treatment and control groups. We don't have the resources for every property to fund an enhanced service coordinator and wellness nurse, so this is the fairest way to allocate what resources we do have and has the added benefit of helping us generate evidence of the program's impacts. The last important part of the research design is the requirement of the treatment group to implement the core components of the demonstration, the enhanced service coordinator and wellness nurse model I described, and for both the treatment and control groups to cooperate with a formal independent evaluation of the demonstration. And a really important part of this is that if you're in the control group and aren't receiving funds to implement the new demonstration model, you'll still receive cash incentives to cooperate with the evaluation, such as participating in surveys and interviews. If you'll excuse me, I have to unlock my computer for a second. I'm losing my WebEx. I apologize for that. My computer timed out while I was in the middle of my slides. So we're on the right slide, thank you. I want to look at the treatment and control groups more closely because this is a different setup of most NOFAs you're probably familiar with, or at least most HUD NOFAs. As I said, the design will involve randomly selecting treatment and control groups from eligible properties. I'll go through the details of eligibility in a second, but I wanted to walk you through how we are setting up treatment and control groups and why that's important. The treatment group will implement the enhanced service coordinator and wellness nurse model, and the control group will continue doing business as usual, whatever level of service coordination or lack thereof that they're already doing. Next slide. We've got a visual here of how this is going to work. In order to include as many different types of properties and properties doing different things, we're going to split properties into two pools, those that already have a current service coordinator and those that do not. And so this means that whether or not you do or don't have a service coordinator, you can and should apply for the NOFA. And then from there, we will assign properties to either be in a treatment or a control group. Next slide. So let's walk through what will happen in the treatment and the control groups. So take a look at the left side of the PowerPoint. This is Pool 1, properties that already have a current service coordinator program. Within that pool, we will randomly assign properties to be in the treatment or the control group. This means that they will have an equal chance of being selected as a treatment or a control property. The treatment group from Pool 1, the green box on the left, consists of properties that already have a service coordinator. They will receive a grant to hire a wellness nurse and augment their existing service coordinator program if necessary and implement the full demonstration model. The control group from Pool 1, the purple box on the left, will receive a grant to implement the demonstration in their property. Will not receive a grant to implement the demonstration in their property, but will receive a financial incentive to collaborate with researchers and assist in the evaluation, up to $5,000. And they just continue their current program. On the right side of the PowerPoint is Pool 2, properties that do not have a current service coordinator program. Within this pool, properties will also be assigned to the treatment or control group. The treatment properties in Pool 2, the green box on the right, will receive a grant to hire an enhanced service coordinator and a wellness nurse and implement the demonstration. Properties from Pool 2 assigned to the control group, the purple box on the right, will receive a financial incentive to collaborate with researchers and assist in the evaluation, again up to $5,000. The major takeaway from this is whether or not properties do or don't have a current service coordinator program, they're eligible for the NOFA, and they'll be randomly assigned to a treatment and control group and will either implement the demonstration or receive incentives to participate in the evaluation. So either way, there's benefits. And I want to talk a little bit, too, about the selection process. Great, thank you. Because that's another really important part for this. So this demonstration is open to owners of HUD-assisted properties that have a minimum of 50 units and are restricted to elderly persons. For those of you housing folks on the phone, properties with the 10% set aside for non-elderly are still eligible. And really it's important to note that participation is critical to building the evidence base needed to increase support of assisted housing for services for seniors. Next slide. So the selection process is really threefold. The selection of the NOFA will start with a review of applications and threshold requirements. HUD is trying to make the application process and threshold requirements as simple as possible. In this NOFA, there are no points and no ratings of applications. So we hope this is going to be a really straightforward process. And then we are going to determine states within applications, and HUD will rank these states to determine the ones from which we will draw applications to the lottery. States will be ranked according to a formula that will consider 3 factors that are critical to ensure that the demonstration and evaluation are successful. The first factor is the availability of healthcare data that can help us determine the impact of the program on health outcomes. HUD will use the rate of Medicare fee-for-service enrollment to capture availability of healthcare data. The second factor that will be used to rank states is the availability of relevant healthcare coordination initiatives that can help bring services and supports to residents. HUD will use the number of relevant initiatives by the Center for Medicare and Medicaid Services as a measure for this factor. And the third and final factor that will be used to rank states is the availability of a large pool of applicants to ensure that the demonstration is manageable and not spread in too many states. States with more eligible applications will rank higher. So again, it's critical to not only apply for the demonstration, but that properties encourage other properties in their area, in their state, to apply too. So they're not competing against each other. The more applications from an area, actually, the better, because it's going to increase the chance that the state will be considered for the demonstration. And the last step in the selection process is to apply the lottery within states and within the two main pools of applications, those with a service coordinator and those without, what I showed previously. The lottery will randomly assign 40 applications to the treatment group and 40 applications to the control group. And there, in our NOFA in section 5B, there's a lot more information about the lottery process. And we can go to the next slide. Just want to touch briefly on the submission process. If any of you are property owners or will be talking with property owners or interested parties in applying, this does have to be done through grants.gov. And so there's sort of 5 steps that need to happen. The first is obtaining a DUNS number, Data Universal Numbering System number. If you don't already have one, you have to obtain a DUNS number. Prior to requesting a DUNS number, you should investigate whether the organization already has one. So you can ask your organization's chief financial officer or grant administrator. After that, you have to register with the System for Award Management, SAM, at sam.gov. And then you create a grants.gov account. And so we have to do it through grants.gov. The website can be a little intimidating at first if you've never used it, but there's some really great resources on it, video tutorials on how to use it. And then you can submit an application on behalf of your organization. Next slide. You can also download the NOFA I'm talking about, which has a lot more details than I can cover in 20 minutes at grants.gov. The easiest way to find it is in the top right, there's a search box, and if you put in Supportive Services Demonstration, it should be the first one that pops up. You can click on it. There's going to be 4 tabs. Really confusing, and the far right tab, if you click on it, there's a place where you can put your email and click enter, and then you can download the package. There's 2 places to download. The very top one has a zip file, which has our NOFA in it. So unfortunately, grants.gov doesn't make it super easy to find a NOFA, but it is there. And I just want to end with a couple of important takeaways. So grants.gov is a great place for technical questions. If you have any programmatic questions about the NOFA I'm talking about or what we're doing, the best place to contact us is mfsc@hud.gov. That stands for Multifamily Service Coordinator at hud.gov. So you can email us there. Next slide. Our application deadline is April 18th, 2016, and so all applications must be submitted through grants.gov. So really be helpful if you can get the word out to people you may know who are interested in applying. We've tried to make it as easy as possible. Still a lot of time, plenty of time to register on grants.gov. And I'll leave you with the very last slide, some FAQs. So we've got 2 links there. We've taken 20 of our most popular questions and really tried to answer them very thoroughly, and we have a PDF of that. We also have almost 200 additional questions and answers posted. These are questions that people have emailed us, and we've put them all there on a PDF, and so hopefully that'll answer questions too. But I've kind of already gone through my spiel, and happy to take additional questions from the audience. Okay, it looks like I've got one here. Can the 50 units be across more than one age-restricted building that the nonprofit owns, i.e. 25-unit building and 35-unit buildings? If so, would they need to be in the same city? So this is a really great question. So the answer is complicated. For the most part, we are going to be looking at each building has to be at least 50 units unless it's in what's called a campus setting. I know a campus setting isn't a technical or legal definition. What we're using for this NOFA is a campus setting is if you have multiple buildings right near each other where a service coordinator could essentially walk across the street. So in this case, if they're in different cities, and one had 25 and one had 35, unfortunately, neither would qualify for the demonstration. And I probably jumped the gun on question and answer. I'm just really excited to talk about this. So I don't know if our host wanted to.
No, it's great. It's great. The one thing I want to jump in is that if folks, you can use the chat box to send questions. You can also email if it's easier, health@nw.org, and we'll take questions that way. But audience is always more important than the folks on the other end. So please feel free to send your questions in. And while we're waiting for more questions, one question I had was actually about the evaluation and when do you expect to get preliminary results from this, so that we know the sort of the effectiveness of this.
Sure, that's an excellent question. So right now this is, we're hoping to really ramp this up very soon. The implementation, the actual demonstration is set for 3 years with a 4-year evaluation. And so we will probably have some mid-term preliminary results, maybe a year and a half in, but probably full results not until 4 years from now.
Fantastic, and I see a question, does the housing have to be public housing, or can it be tax credit or other affordable senior housing?
Oh, great question. So actually this is not in public housing at all. This is restricted to multifamily housing. The NOFA, if you download it, has all of the different properties that are going to be eligible, but it tends to be things like 202, some of the old Section 236, PRACs, et cetera. So it's going to be in multifamily housing, not public housing.
The next question is, we have 70 units, project-based Section 8, 223F, HUD-insured mortgage financing. Are we eligible?
So I'm going to say probably, and I apologize for not telling you 100%. So I am on the research side of this. I do not sit in multifamily housing, and I do not want to say absolutely you are eligible. And I say probably because that sounds reasonable. I would go ahead and check the NOFA, or you can email the mfsc@hud.gov, and someone from on the housing side who does all the eligibility and deals with all the types of housing provisions can answer that more directly. So I apologize, I don't have a complete answer, but it's going to be typically any of the multifamily housing with at least 50 assisted units that are elderly restricted or elderly designed or elderly designated, right? So what we're trying to do is have at least a 50-unit count in multifamily buildings that are really serving elderly residents.
Thank you. And my impression when I read the HUD NOFA, I can't remember every single example, but it's the broad HUD assisted, and I think my sense is that folks who feel like they might not be eligible but expected to be eligible are folks who have smaller properties. But there's a lot, it's most of the HUD assisted categories. Then the next question is, can you send us these slides in an email attachment? So we will post them online, these slides, and I assume from the NeighborWorks side. And then Leah, I don't know if you have them posted online either.
We don't actually have the slide deck posted online anywhere, so please feel free to send them out to your audience and to your network, but no, we don't have them currently posted anywhere.
Great, so we will be sending them out so you'll be able to see it, and we'll certainly send it out also to folks who registered specifically.
We also did, I unfortunately don't have the link with me, we did a over an hour-long webinar going through a lot of the details, more so than I did this time, pretty much the same information, but more expanded. The webinar should be available on YouTube. NeighborWorks folks, I don't mean to put you on the spot, but if I find that link, could I send it to you and have you send it out to folks that have registered?
Absolutely, we can send that out. And I also, there's a fact sheet that you guys put together that's really helpful, and we'll try to figure out a way to link that so folks can see that, because the fact sheet, I think, listed the specific HUD-assisted properties that would be eligible as well. So that's another resource for folks.
Great, thank you.
And one question, just in case other folks have other questions, I'll ask you one question that I've been thinking about is, as you guys were developing this NOFA, can you share some of the different models that you looked at to inform the design, or some of the evidence that you looked at? It would be very helpful, sort of, because there might be folks on the line who aren't eligible but are interested in sort of learning what you guys learned as you thought through this process, and so that they can sort of take some of those lessons to, you know, how they approach their work.
Sure, absolutely. So I hope everybody is going to be tuning into the whole webinar, because I know the SASH folks are talking, and they were a really influential piece in this, and I'm sure you'll notice some similarities between what I've shared and what they're sharing. We're not trying to replicate SASH, but it certainly informed our decision making. We also looked at a variety of care coordination models that were tested by CMS, the Centers for Medicare and Medicaid Services, because people are trying to do similar things. Because one thing that a lot of folks have noticed is that there are linkage issues, linkage with social services, linkage with health services. So a lot of the people that HUD serves are going to be eligible for Medicare and Medicaid, but and eligible for the benefits that are covered, but have trouble accessing, and then have trouble sort of filling in the gaps in their care coverage. And so there are a number of models, SASH, the CMS ones I mentioned. We also had a previous report that came out by the Lewin Group and Leading Age, looking at some demonstration models that could help inform this research, that really helped us arrive on the service coordinator and wellness nurse model.
Thank you. If there are no further questions, I have the honor and the privilege to turn this over to Susan Duard, who's from the Northeast region. And I forgot to mention when I started this, that this webinar is a collaboration between Healthy Homes and Communities here at NeighborWorks and the Northeast region. So thanks to Susan and Lynn and all the great folks out there. And I'll turn it over to Susan.
Thank you, Sarah. And on behalf of me and my colleague Lynn, who's the relationship manager for real estate for the region, you know, we really want to welcome you and thank you for joining us. Lynn and I are the health champions for the region, so we work very closely with Sarah and her team. And early in our careers, both Lynn and I were social workers at affordable housing complexes, so we're big fans of SASH. SASH proves what we all know, that with the right services and support, people live longer and with a better quality of life at home and as part of their community, and that doing so saves taxpayers dollars, and that housing providers have an instrumental role to play but need a steady source of funds to be able to do so. So 4 NeighborWorks organizations in Vermont participate in SASH. 2 of them serve as regional hubs for the program, and between them are responsible for about 1/3 of the state, and that's who we have with us today. We are so thankful for them for making themselves available to talk with their network peers about the ins and outs of SASH and the lessons they have learned that you can take forward as you consider designing your own program, whether it's for this RFP or beyond. They'll begin with a presentation, but we'll have plenty of time for Q&A afterwards. So with that, I'd like to turn it over to Eileen Peltier, Executive Director of Downstate Housing and Community Development, located in Barre, Vermont, and Tricia Ingalls, CEO of Rural Edge, located in Lyndonville, Vermont.
Okay, can everyone hear me? Can someone hear me? This is Eileen. So good afternoon, everyone. I just wanted to start, I was trying to figure out how to unmute my line so that I could ask a question of Leah, but one thing, if I was a housing group considering this particular program or any particular program with HUD, you know, we all have our share of concerns about whether or not they're able to administer a program like this effectively. And you heard Leah say that it was, you know, they've never done anything like this before. So I was going to try to prompt her to say what I happen to know, which is they are planning on hiring a large national, there's a separate NOFA for who's going to administer this program that will provide the training and collect the data and do all those kinds of things. So that won't be trying to run through HUD and everything that happens there. And I think that's important to know if you're thinking about applying for this program, that in fact, it should be a tight process and well run. So I just wanted to say that before I get started. So Tricia and I are going to go back and forth a little bit. I will get us started with just sort of an introduction about where SASH came from and what it is and some of the basics. And we are hoping to be done by 3:30 at the latest and give you a good chunk of time to ask questions. So if we can see the next slide. So just to begin, what is SASH? So SASH harnesses, this is the only slide I'm going to read, I promise you, harnesses the strengths of social service agencies, health providers, nonprofit housing organizations, and the SASH participant to work together to support to live safely and healthfully at home. So that is our vision, and right from the get-go you understand our goal is that people age at home, however they define home, and that it is clearly a collaboration of partners coming together, social service agencies, healthcare providers, whether that be your primary care physician or the local hospital, all of us as housing organizations, and most importantly, the SASH participants, so the individual participating in the program. Next slide. So this is just a different reflection of this, but the quote on the left is one of my favorites. Housing is a point of natural aggregation of high-risk individuals. So in Vermont, we are tapping into 136 different locations across Vermont where we know study after study has identified that the people who live in our housing tend to be sicker, tend to have more chronic illnesses, tend to use more Medicare dollars and Medicaid dollars. So we are tapping into housing, our housing, which there's some great slides out there that show if you put a dot everywhere, there's a NeighborWorks housing or affordable housing or LIHTC housing or public housing. It covers the whole country. And if you imagine that as a wonderful opportunity to impact both positively on people's health, but also positively on the cost of health care, because we have this congregate population of individuals who we know through data research, through Medicare and Medicaid, that they're higher cost users. So this slide is giving you a sense that we are pulling all these different agencies that I mentioned before together. And so in Vermont, and it will be different around the country, but some of them will generally be the same, we bring together the hospitals, the nonprofit housers, home health is another word for VNAs, if you use that term, your local designated mental health agency within your state, your area agency on aging, and what we have in Vermont, which is medical homes, which we'll talk a little bit about later, but that is another connection into a state program that is part of that SASH is part of under the Medicare pilot that we're going to be talking about in a second. So why are we doing this? I think this is the most important question, and I'm guessing at this point, if you're on this call, you probably have at least a sense of this if you haven't seen this slide. This slide's been seen everywhere across the health and housing conversation, which has been really ramped up since the Affordable Care Act happened. So basically what this slide is saying is why should, in translating it for all of us who are housers, why are we involved in the conversation about health care? Well, this is why. If you look at the slide, it says the following. It says behavioral patterns, social circumstances, environmental exposure. Add those three up, 60% of it are all factors that are deeply affected by the existence of a home, by the way that you live within that home, all things that we can impact as people who are interacting with someone in their home setting. So 60% of it is there's great opportunity there. Genetics are genetics, we can't do much about that. And then there's this like purple pie piece, the healthcare one, which is the one that we all think of is how we manage health. In the United States, we think about healthcare as this purple slice, but what in fact this is telling us is that that doesn't really determine whether or not you live a healthy life. So it makes a lot more difference whether you eat, the French fries for dinner or you eat the broccoli for dinner. That's kind of another version of what this is saying. So next slide, please. So this is just some data on what I was starting to say, what I was saying earlier. So our residents, people who live in HUD-assisted housing, are expensive. So what we know is that, look at the first one, Medicaid fee-for-service, we're 32% higher for people living in HUD-assisted housing. Medicare, of the group that they were looking at in HUD-assisted housing, 68% were duly eligible. So just to explain what that is, duly eligible means that you both qualify for Medicare and Medicaid. So you're low income, disabled, you're accessing both systems. Typically dual eligibles are sort of the highest need, highest cost population. And I think remembering too, when we're looking at all these numbers, just because they're the highest cost doesn't mean they're getting the best care. So there's huge opportunity, and we talk a lot when we talk about this stuff about the great successes we've had on saving Medicare money, but I think when, if you ask Tricia or I what we're proud of, we're way more proud of that we fully believe our residents have a much better quality of life. So just want to put that out there as we go through this. So you can see 55% of people living in HUD-assisted housing have 5+ chronic conditions. Medicare costs 16% for HUD-assisted housing due to higher usage. So lots of data out there. Those are just some samples of why we're involved in this conversation, why we should be, you as groups should be thinking about being involved in this conversation. Okay, next slide. So now I'm going to move to just talking about what SASH is and what we did with it. So the most important thing to know is that when we started SASH, this is actually the group of people, not all of them, but the group of people that sat down and designed SASH along with staff from Cathedral Square Corporation. So when Cathedral Square first started this pilot, it was just a one little pilot at one little housing location in Burlington, Vermont. There were, I believe there's 90 apartments in this development, and the whole model was designed by this group of individuals. And that's important to note because it works for them, because it was designed by them. So as you're thinking about developing models, you want to be thinking about having that group that is, you know, whether they're your sort of consulting group on the side or, you know, they're participating in the conversation. So next slide. So I wanted to just take a minute because I feel like there's so much information there about SASH, and there's out there kind of nationally, and probably some of you on the call have heard either myself or Tricia or someone talk about SASH in the past. I just want to give you a little overview of how the heck we got here. So in 2009, that little pilot that you saw the picture of on the last slide began. There are about 59 participants. And a lot of the core concepts of SASH that you'll hear Tricia and I talking about in the next 20 minutes or so came out of that group, or sort of came together in 2009. And then in 2010, we had some amazing data that we didn't, we were hopeful, but it was pretty impressive. And just one data point you see there, almost a 20% decrease in hospitalizations for the participants that were participating in SASH. This is in a year when they didn't even know what it was yet. They were making it up. There was, great reduction in falls, reduction in return to the hospital. Lots of, we measured like 4 or 5 different data points, and they basically all looked good. So there got to be a lot of excitement. At the same time, coincidentally and fortunately, the state of Vermont was chosen to participate in a Medicare pilot, which sounds kind of crazy in and of itself, but Medicare basically said, we're going to pick some states to participate, to do something different that's going to figure out how to reduce the overall Medicare payments to the state. So really simply, imagine that Vermont got $1 million, which is, several zeros short, but it got $1 million in Medicare funding. Basically, the pilot from Medicare said, do something, you have to get it approved, but come up with some crazy idea, and as long as you don't spend more than that $1 million and, you don't grow over the 3 years, we'll be thrilled. So SASH is part of Vermont's program, that larger pilot, and we consider ourselves an extender of that program. The program is called our Blueprint for Health. So so in 2011, we started talking to the state about what they were doing with this Blueprint for Health thing, and we said, we can save Medicare dollars if you give us money to implement this model, which is hiring staff through the housing organization and doing this intensive, support to allow people to age in place. So the game changer for that program happened when basically SASH went to D.C. and said, okay, people, we can do this and you're going to pay for it, and Medicare agreed. So I think that's the game changer in all of this, and that's the success that our biggest success was getting Medicare's attention to say that housing organizations and our staff can actually affect the cost of Medicare. So that was sort of the game changer. We spent the next 3 years growing it, proving it, and we will talk about over the next few slides about the results, but they were impressive and good, and it's been a very successful program. We're to this point where we have about 5,400 participants all across the state, and we'll talk a little bit more about what the program looks like in kind of in the specifics, but just to give you that landscape of what we're looking at. So there was this sort of critical moment where Medicare said yes, and we were able to test it, and the outcomes were good. So fast forward really quickly to just this past fall, SASH was asked by HUD to have a conversation with them about this program, and was there a way for HUD to do a pilot that used some stuff from us, and, clearly it's not all SASH, but it's similar to SASH, and you'll see that as we describe our programming ahead. So I think that was related to the results that you're going to see, and I think it's very exciting that HUD is willing to do this, but of course they're using HUD dollars to develop this program. So they're also saying we should be doing it because it makes sense for our residents to be doing it. Okay, next slide. So now we'll start talking a little bit about the model itself. So there are 3 components to the model. The first being care coordination. So the SASH coordinator, there's 2 primary staff who are on the ground working with a panel being 100 individuals who are accessing the services of SASH. So the SASH coordinator and wellness nurse have 3 functions. They do care coordination, which means they do these overall wellness assessments. They pull the convening of what we call the SASH team, which is that house with all the different puzzle pieces that told you who the different participants are. They all sit down together either biweekly or once a month, depending on the panel and what makes sense, whether it's rural or urban or how it works. But generally, they meet at least once a month to talk about individual care coordination needs. And in any given month, they may talk about 10 or 15 individuals. Not everybody has needs at the same time of that panel of 100. So there's care coordination functions. And then under self-management, we do a lot of work. So SASH coordinators, a big part of their training and what they do is helping individuals. So coaches is the best word for it, I think. So they coach the participants on healthy living. They've developed a healthy living plan. So if you are an individual with diabetes and you want to reduce your need for insulin by, losing weight, then we might help you develop a plan that teaches you how to eat better around nutrition and, maybe do an exercise program. So those types of things. They're individual healthy living plans. We might do reminders. We might do check-ins. There are certain people we check their blood pressure on a regular basis. And then we coordinate a lot of different, what we'll talk about a little bit later, evidence-based programs. So we have a whole study of a whole bunch of different evidence-based programs that we might introduce at the community level. So, for example, it might be something like if we identify that there is a population of people who would benefit from chronic care self-management tools, we might teach a course on that and do a presentation, work with people on that. And then the third big chunk of what SASH does is transitional care. So kind of one of the most traumatic events for individuals is a transition in and out of hospital, and often back to the hospital, because when they come home, they don't necessarily have everything that they need. This is funny, now I'm having the problem, my computer just shut down. Hold on 1 second. Okay, I'm back. So under transitional care, they either don't have what their needs are and they end up back in the hospital, or they misunderstood their medication, they end up back in the hospital. So it's both a traumatic event for the individual, and we all know it's a high cost, an ambulance, a visit back to the emergency room, potentially back into inpatient is a lot of money. So we focus a lot of attention around transitional care, and this is where we work both directly with discharge staff at the hospitals, but also with family members, helping them, ensure that they've got everything they need to assist their family member who's transitioning back home, and if they don't exist, or maybe in addition to that, neighbors, and sometimes if there's no one else available, our SASH coordinator is really stepping into that role. So they may, be bringing somebody home from the hospital, making sure their meds are lined up, they have what they need, and they do that sort of personal visit to help them with discharge. Okay, next slide. So the last couple slides for me. So I think this is a great way to describe what SASH staff are. They're trusted guides. They're this consistent presence within the housing setting that are available to individuals. And I think, intuitively and through experience, we all know oftentimes one of my favorite lines is that my maintenance guys are my best social workers, and it's because there's consistent presence, and they see people and they talk to people. So SASH staff is allowing, one of the great benefits as a housing organization to this program has been relieving my maintenance guys and my property managers from worrying about these things. They have knowledge that an individual might have a need or is struggling with something, and they don't know what to do with it because it's not really their job to be helping somebody figure out their meds, or, they're worried that somebody's not getting out and, buying their groceries or getting out on a sunny day just to get a little fresh air. They have a place to put that concern, and so SASH staff really become that consistent presence on site, and they become the trusted guides to basically help people manage their own process of aging in place. Okay, so next slide. So just very briefly, this is an overview of kind of using the same intervention areas, what the two functions are, whether it's the SASH coordinator or the wellness nurse. So I'm not going to go into all of these things, but I thought I might spend a minute talking about the SASH coordinator is an individual that often has a social service background, social work background, but does not necessarily, it is not a requirement. They are not a licensed individual. They are highly trained. We have a huge training component to what we do, and they get certified in a variety of different programming tools, but they're not licensed. And of course, the wellness nurse is a registered nurse and is licensed, so the split, tends to represent that. And then last slide for me, and then I'm going to turn it over to Tricia. One more slide, please. So key concept of SASH is that it is a person-centered program. There's this great slide where we have an elderly individual, and she's holding on to a steering wheel really tight, and it says above it, Katie's in the driver's seat. And to me, that sort of exemplifies what person-centered care means. So they are driving their process of aging in place, and we are guides and support to that. So I've already mentioned staff are embedded in housing. There's lots of formal partnership with all those individuals throughout the puzzle piece. And one of the key concepts or the key priorities of SASH is that we can actually share information. So in the old days we couldn't. Now we have a legal structure, a memorandum of understanding that actually allows the Council on Aging or the Visiting Nurse Association to talk to the housing entity. So that's a key part of SASH and what allows us to be successful. Okay, I think I'm going to turn it over to Tricia now.
Hi, I hope everybody can hear me okay. So Eileen just did a fantastic job of describing very clearly what is a fairly complicated program sometimes, you know, and you might be wondering, okay, so what does it actually look like? So part of this presentation is actually taking you through, you know, what a SASH coordinator does. What happens when that first contact is made between the participant, the wellness nurse, and the SASH coordinator? So you're going to meet Guy. I don't know how common a name that is in the rest of the country. We're moments away from the Quebec border here, so that would be Guy, fairly common name around here. But anyway, Guy is an actual SASH participant. He lives in St. Albans, Vermont. He and his wife, Teresa, live together, and they recently moved into, you know, some congregate housing. He's 78, he's easygoing, he still drives, which is important, and they're pretty independent. But he also wears a portable oxygen mask most of the time. So if I could have the next slide. So, you know, the SASH coordinator, I'll use a name of one of our staff, Gary, for example. So, you know, Gary would get a referral to meet with Guy. And, you know, they would set up a person-centered interview, and SASH staff do get training on how to do person-centered interviewing. And, you know, he would ask Guy a series of questions, and part of it might include this preferences map. So, you know, what's the status quo for Guy? You know, what's working well now? Well, for example, you know, he is still able to drive himself. So he can get to appointments on his own. You know, transportation is not going to be a barrier for him. And he's unlikely to become isolated and suffer from loneliness. And also, you know, he still has his wife with him. And so what's not working? So it might be important to find out, you know, is Guy connected to services? You know, if so, great, which ones? And if not, then why not? You know, what might be the case with a couple like Guy and Teresa, because they're a couple and they recently moved into congregate housing, they may have no idea what's available to them in terms of services and care in the community. And then it's also looking ahead, you know, 5, 10 years down the road, what's Guy going to need? So if I could have the next slide. You know, the next step is really mapping out who is in Guy's life besides his wife, who could be called upon to help, who could be included in decision-making if need be. So, you know, this is a really good example of what this relationship map could look like. So, of course, he has his inner circle, and then his wife presumably would be in there as well. You know, and then you kind of go out from there. Who else in the community? You know, there's his pastor, there's his brother, and there's a friend, but he's across the country. But all of these people could be kept in mind, could be part of his assessment, you know, listed somewhere as possible contacts in the event that Guy needs help or support in the future. Gary, my SASH coordinator, has also recommended always adding the primary care physician onto this map, you know, whether they're best friends or they've only met a couple of times, including the primary care physician is really important. So if I could have the next slide. So Gary would sit with Guy and conduct the person-centered interview, and now we know a little more about him. He and Teresa have been married a long, long time. They have a lot of kids and great-grandchildren, and he, you know, worked in the automotive field. Something really important is he and Teresa both like to volunteer as foster grandparents at the local elementary school. And so he doesn't want any of his health problems, and he does have some. He doesn't want those problems to stand in the way of that activity. There's a lot of cancer in his family, and he really likes to be active. He likes woodworking. So, you know, Gary and other SASH coordinators have said, you know, when you sit down with someone and you find out about them and you start creating goals, oftentimes their goal is really just to keep going. You know, they might not want to learn Spanish or, you know, visit the Caribbean, but they want to stay healthy and keep doing the things that they're doing. So that's often, you know, one of their main goals. And so then it's how do we go about using this information to make connections, to set some goals, and to fill any gaps that might be there. So if I could have the next slide. So data collection. You know, SASH is really good at keeping track of data, and the coordinators are all trained in this data collection as well as the wellness nurses. And everybody understands that it's the data that is going to keep SASH going. It's what demonstrates what a strong program it is. So everyone is really taking data collection very seriously, which is great. So there are a number of assessments that are part of the this initial assessment. You know, the SASH coordinator will typically do 1 to 4, and then the wellness nurse will do the rest. You know, most of them are fairly self-explanatory. Some of them, you know, are fairly specific. For example, the PHQ-9 is really if there is a possibility of some substance abuse happening, which is possible. So sometimes the SASH coordinator and the wellness nurse will sit together with the participant and collect this data, do the assessments. It can take a while, usually an hour, hour and a half. You know, it's not the type of thing that you want to rush. You want people to feel comfortable, and it's really trying to create a relationship. Sometimes in the case of a male SASH coordinator like Gary, some of his female participants feel more comfortable, you know, doing some of the more you know, health-related assessments separately with the wellness nurse only, and that's fine. You know, it's like Eileen said, the participant is in the driver's seat, and what they say goes. So you collect this data, and then if I could have the next slide, you figure out what you learn. And so could I have the next slide, please? Well, I'll keep talking anyway. So we learn a number of things from Guy's assessment. It turns out he's actually taking more than 10 medications and over-the-counter pills. That's a lot. He has multiple chronic conditions. So then it's kind of triaging those and what is bothering him the most. Well, it turns out that of all of his conditions, the lymphedema in his legs causes him the most distress and is the most disruptive to his daily life. So that means he gets some fluid in his legs and it causes swelling. And then a nutritional screening shows that he has a moderate nutritional risk and a high BMI. You know, a lot of factors could be contributing to the nutritional risk. You know, the fact that he takes so many medications, he could very well have a high copay. If he and his wife are on a fixed income, you know, they have these medical bills as well as heat, taxes. So, you know, the SASH coordinator will be looking at, well, what's out there for Guy in terms of, you know, food and meals availability in his area, and so on and so forth. So now I'm on to the slide after that. I don't know if that could be changed fairly quickly. So, anyway, there is a interprofessional team approach. So you have, you know, the participant always in the center. And then the nonprofit housing organization is really key. And we believe that that is what helped lead to the success of SASH, because it's really having access to people on a very regular basis and developing the relationship that lets you know whether or not people are doing okay. In addition to that, get in touch with your local area or council on aging, your visiting nurse association, your community mental health agency, all the things that Eileen mentioned in her part of the presentation. And then an additional circle around that is really, you want to have your hospital on board. You want to know who works at your hospital, who can help you. You want to have contact with your nursing home. The primary care provider is very important. A lot of people haven't visited their physician in a long, long time, so often just getting them back on that regular schedule of checkups can make a big difference. And then something that's fairly unique to the Blueprint for Health in Vermont is the community health team, and that's made up of all of those same partners. So if I could have the next slide. Some of the domains of care planning, they're all listed here. I'm not going to read them, and hopefully you can see them. But basically, these are some of the areas of consideration for creating a healthy living plan with the resident. So, anything from, getting them insurance, finding them a primary care provider. Food and nutrition support is often a big one, making sure they have adequate housing, and so on and so forth. So depending on the needs of the participant and how sick or not that they are, you would want to review this healthy living plan. Generally, every 12 months, they need to be reassessed. Otherwise, if it needs to be more frequently, then that is doable. That's something to be decided between the SASH coordinator, the wellness nurse, and the participant. So on the next slide, you have a picture of a team brainstorming to help Guy. So this is an example of, an issue that came up. Guy needs to wrap his legs because of his edema problem. Wrapping his legs is really critical to his mobility, to being able to walk around, to be able to drive. So his wife, Teresa, has been wrapping his legs every day for him. It reduces swelling. But Teresa is in a place where she can't do that for him anymore. So what are the possible alternatives? So you see here a bunch of team members from the Council on Aging, the home health, mental health, the coordinator, the wellness nurse. The participant can be involved as well. So if you go to the next slide, we start action planning. So this is really the beauty of SASH, is you take a participant with a particular problem, you take a room full of people who are really good at what they do, and you bring them all together to brainstorm. So the problem is, this lymphedema is his biggest impediment to his independence. So what can we do? And then the other, big thing that is really important to Guy is he wants to keep foster grandparenting. That's really important to Guy and Teresa. And if he can't find a way to get his legs wrapped, he's not going to be able to do that anymore. And his health, if he can't get around, will probably deteriorate fairly quickly. So if you go to the next slide, you have here a chart that could be used at a typical meeting. So what you would do is take, the 1, 2, and 3, the task expertise, the relationship, and the capacity, and you would kind of chart them. Okay, so the SASH coordinator is a 1. The council on, the agency on aging is maybe a 1 and a 2. The physician is probably a 3 and a 1. So you go around the circle and you kind of chart out, okay, who in the end should really be responsible for making sure that that Guy can meet his goals. And then the wellness nurse is often responsible for referrals and getting, following up and checking in. So if I could have the next slide. What can often happen is, okay, we try a number of different, scenarios. So the Council on Aging applied for a Medicaid waiver. He didn't meet the eligibility criteria. Okay. The Home Health Agency explored skilled nursing, but Guy is not homebound, and leg wrapping is considered maintenance, not eligible. Then the SASH coordinator explored private pay, you know, just hiring someone to come do it. It was too expensive, and they couldn't afford it. So, you know, that seems like a lot of slammed doors, and if Guy had tried any one of those options on his own without the benefit of SASH, he could have gotten really discouraged. And, you know, so just the fact that he had a team working for him made a huge difference, because then, you know, he called in for a referral to physical therapy. He didn't qualify for home visits. However, he qualifies for physical therapy as an outpatient, and he learned how to wrap his legs himself. And here you have a picture of him starting that process. So he had never been shown how to do it properly, and he didn't believe he could do it. But, you know, he had a lot of encouragement from his team, from his SASH coordinator, and now he can do it himself. And then he has a wellness nurse who visits him, who can make sure that everything is fine, monitor his vital signs, and, you know, that's great news. Guy can keep driving, he can keep walking, he can keep living independently, and all because, you know, he had a team of people really looking out for him and problem solving when you run up against all of these barriers. This is the end of my section for the time being. I think Eileen is ready to get into the next part.
Yep, so I'm just real quickly going to just run through some of the things that we're looking at. So you heard me mention earlier this evidence-based programming. So something that SASH did early on, we actually got a couple of medical students to take a year off and develop this fabulous database of evidence-based programs. So they did research, you know, all over the place, and came up with programming that's effective for helping seniors age in place. So we have available this database, and when we're at an individual community, so I'll use mine as an example. We have like we're pretty rural, so we have 4 different properties within kind of a 15-mile radius that are one panel. And we noticed that a huge percentage of that whole group, when we looked at the data pulled together, had an arthritis problem. So we started a Tai Chi class that we teach at one of those sites, and we use big television sets and the internet, and it's offered to all 4 different sites. So that's what we're talking about around evidence-based program and sort of the community healthy living plan. That's the idea of looking at the whole community and sort of identifying themes and creating programming around it. So you see on this slide some of the different things that are available. So next slide. So then there's just some stuff we've been looking at and working on. So this is just telling you that the number of participants who were, and this is, we're using the same subset. So over the course of 4 years, you know, we've gotten a lot of people immunized for shingles, and they've also had their annual flu vaccination. So next slide, similar type of information is on advanced directives. So same thing, advanced directives, we all know they're very important. This is just showing you, sort of, it's a little hard to see, but you can see the number of people who have had their advanced directives done. So we have a big initiative, and that's something SASH coordinators were trained around, and they are able to work with a participant of SASH on this. So next slide, please. So again, we know from all kinds of studies that having a primary care physician is incredibly important to the success of your health. So making sure that everyone has a primary care physician, another big effort that we undertook. And then the last slide just shows that the increase in the number, actually there's a couple more slides, the increase in the number of people who have actually, you know, it's one thing to have a primary care physician, there's another thing to actually have a preventive annual exam and stay on top of things, so working on that. And then lastly, this slide looks at a little bit about the difference. So hypertension, the blue number is the number of people who have controlled hypertension. So this is a population we work with, and you can see only 4% were controlled, and by the time 4 years later comes around, 60% have controlled hypertension. And then just a last slide in this area is related to that. So high blood pressure was a big issue, controlling that. You all probably know high blood pressure medications, come and go, and they're often confusing to individuals, and just compliance with that medication can be challenging. And then, so we did a statewide training of the SASH coordinators and the nurses on hypertension management protocol. We gave the various different sites, you can see on the table, they got their own setup, so they learned how to educate SASH participants on whole blood pressure monitoring. There are little tables like this, whole blood pressure stations at many of our SASH sites to ensure that people to help them be in compliance and have controlled hypertension. So I think I am done at that point, so just talking about the programming. So I think hopefully it's clear that there are a couple different, there's a SASH coordinator, there's a wellness nurse, and there's two primary goals. One is the individual work, which you heard about through Guy, and then there is more the community level work where you hear about the example of sort of doing Tai Chi because we identified that arthritis is a key factor. And it didn't come up here for Guy because he's out and about, but socialization, as you all know, in your properties, you can see it, is a huge issue. So the community-based programs not only help with physical health, but they definitely help with mental health, and depression was in our first run at doing the surveys and interviews with our participants. About a third of the residents self-identified depression. So the community-based programs are important for that reason too. And then Trisha's going to talk about the financial results.
Yeah, I mean, I just want to talk a little bit about the results. It's kind of like the who cares question, right? Or if you're doing results-based accountability, it's so how well did we do it? And we did really well. So, you've had this slide up for a few seconds. We've done 2 full evaluations so far. They've been, by an independent company, RTI. Overall, the growth in total Medicare expenditures was $1,756, which is over $2,000 lower per person than the growth among the 2 control groups. So that's material. That's really significant, cost savings to the Medicare program. If I could have the next slide. We'll talk a little bit about challenges. So of course, as you all know, the reason you're on the webinar is finding a sustainable funding source. For us, we are still part of the demonstration program, the original one. It's been extended a couple of times. So finding that sustainable funding source is key. The HUD NOFA will offer that to get you started, and then it's figuring out what happens beyond there. Getting partners on board, who do you talk to at the hospital? How do you first reach out to your agency on aging and your home health nurse? Eileen does teach a really great class at one NeighborWorks Training Institute a year, I think. She can correct me if I'm wrong. There is a bit of a shortage of administrative funding. It's really tough to do kind of the overall, paperwork and getting agreements signed, finding the funding for that person to kind of handle all of the admin stuff. IT is a challenge for everything we do, it seems like. So, getting a system that works really well, that everybody is on board with using and can use consistently is really important. Mental health, they're subject to some really stringent confidentiality rules, and it's still a challenge to get them to really share information about participants, at least in our area it is. But, you know, they are at the table and they are doing the best they can within their constraints, and they're a very valuable player. And then, you know, having multiple funding sources, if you get funding from more than one place, it means, you know, lots of reporting and multiple applications. So if I could have the next slide. But, you know, the success drivers make it worth it. Having a great outcome like Guy happens every single day. You know, if it only happened once in a while, we wouldn't be having this conversation. It literally happens every day where we make a difference in someone's health. So like Eileen said at the beginning, that's really what the driver is for us. Like I mentioned a little while ago, you know, having housing as the basis for the program, I think, has made a world of difference. A population-based approach is also, you know, a great factor, because you may have a bunch of people in a building, they may not all want to sign up. But then, you know, the more they see activity, the more they see the lives of other people improve, the more interested they may be in improving their own health. The flexibility of the funding was really key, because it allows us to help people in the way that they need to be helped, and it doesn't confine us. You know, one of the problems we hear often about social services is that you really have to fit into some really tight boxes in order to get funding from certain places. So having the flexible funding really lets us help people in the best way for them. And, you know, as we said, SASH was designed with those 59 participants. They had a huge role to play in developing the program. And having data, you know, collecting the data and analyzing it, having Cathedral Square, you know, analyze all of the data that all of the coordinators are getting, and then reacting to it and building on it is really important. And then, you know, going statewide, I think, has really made a huge impact on the program. And I just wanted to add that if you would like to sort of meet Guy, he's featured in a video. SASH has a great website, sashvt.org, and there is I believe, a media tab, and there's a video about Guy and his wife and his story, and it's a great place to see other videos and more information about SASH. So the next slide is questions. So I think either Eileen or I are ready and willing to take any questions you may have that we can answer.
Thank you so much, Eileen and Tricia. And I just want to say Leah is also available for questions, and so I think I'm going to start the question session off with two questions we got for Leah just before the question period closed. I want to make sure folks get a chance to get those questions answered. So Leah, for the control group, someone wanted to know, is it required for the control group that providers not enhance services at the location for the full 3 years, even with other funds?
That's a great question. So no, there is nothing that we have that says that you cannot introduce other services or you know, enhance your own program. As part of the evaluation, we are going to be trying to understand what is happening at control group properties. So if things do happen to change over the course of the demonstration, we'd want to pick that up so we can account for it. But no, they're not going to be required to refrain from enhancing their own program.
Thank you so much, Leah. Another question that came in for you, I think this is for you. How long would the grants fund the coordinator/wellness nurse positions for, Leah?
So right now we have funding for a 3-year demonstration.
Thank you. And for other folks who want to send questions, you can either email them to health@nw.org or you can type them into the chat box. And we also, you know, I would like to give a chance for questions, but also we will go to opening the line so folks can have a discussion or share work that they're doing in their community that's relevant, because, of course, the work that we just shared today is phenomenal, but there's other models out there, and we want to give folks the opportunity to share those models as well. So we'll give a few more seconds for questions for either Leah or Eileen or Tricia, or Tricia or Eileen, if you have, or Leah, if you guys have questions too, it's your opportunity. Well, with that, I think we're going to open the lines, and if you are interested in sharing work that you are doing in your community or you have thoughts that you'd like to talk about, we'll have a little bit of a, try to do a little bit of sharing. Oh, we have one more question. That's what always happens.
We have a question for Tricia or Eileen. Could you talk about your fee-for-service payment?
Sure, I can do that. So this is Eileen. So as we mentioned earlier, SASH is primarily paid for through Medicare, and we receive basically $700 per participant per year. So the way we kind of think about that is it's rolled up into a panel of 100 individuals, so that becomes $70,000. That $70,000 pays for the wellness nurse and the SASH, so full-time SASH coordinator, regular 40 hours, and a wellness nurse at 10 hours a week for that panel of 100 individuals, and it basically just about works. You heard Tricia say that there are some additional costs that don't get covered. So just briefly, that's the Medicare funding. Then the state of Vermont provides some support through Medicaid, and we have a Medicaid match. So through a few different sources, we get about $1 million from the state a year, primarily through Medicaid, Medicaid match, and through the Department of Aging and Independent Living. And a lot of that money covers the administration of the statewide program by Cathedral Square Corporation, which we can't, we have understated, and I'll correct that. The training and the statewide implementation and the rollout of SASH is a huge part of its success. From day one, knowing it was all about the data, to knowing it needed to be person-centered, and just ongoing training for the SASH, for the people who are on the ground doing this program. It was a huge part of what has allowed us to be so successful. But that's sort of the basics of the money. So $700 per participant per year. And knowing that just, some of them are perfectly healthy and don't have high needs. So within a panel of 100, you kind of get a mix.
Thank you, Eileen. We also have one more question for you or Tricia to respond to. Are there effective responses to the transportation issues experienced by many seniors, especially in northern climates where slipping and falling on ice are more common?
Yeah, I think that's really where all the training that the SASH coordinators do on balance and falls prevention is really important. And that's also what, I'm not going to lie, it is a challenge when we're in an area like ours where there isn't really effective public transportation. It's trying to create those relationships, create volunteers, get drivers. Living in congregate housing is a real advantage there because, I know as landlords, as property owners, we do a really good job of maintaining our properties. But that's a tough one, and Eileen might have something to add to that.
Yeah, just a couple thoughts. So we have a rural transit authority that is very committed, and they're actually one of our primary SASH partners. So we work with them very regularly, and they have some capacity and funding from the state to be able to help individuals who have needs. They do a drive-about, like to some public housing and affordable housing settings and people make their appointments on a certain day of the week to the local federal qualifying health center, so they can go visit their primary care. So where we can partner up and have somebody to partner with, we do that. But then the other side of it is often what will happen is there's kind of a SASH coordinator might know that, Jane needs a ride to her doctor's appointment, and Judy's 4 doors down in the congregate housing setting, and Judy has a car and loves a chance to get out, and so we make those connections and you have those conversations. So just the presence of the SASH coordinator sort of in the community and really getting to know people, and being a person who can sort of ask those questions. You know, they find solutions like that. And then in some cases where we don't have any of those solutions and somebody needs to get to an appointment or get somewhere, sometimes our SASH coordinator is doing that role. But that's not our ideal solution.
Thank you. That was really, really, really helpful. And we do have a few more minutes, and I thought what we do is open the lines, and if there's organizations who are interested in sort of sharing either sort of successes or the work that they've done at this to serve older Americans to age in place, they could do that, or if there are particular challenges that they want to bring up and share, they could do that either. But we wanted to sort of offer the opportunity for a little bit more of a discussion. So with that, I'm going to open the line. And I will not put
the leader has unmuted your line.
I've opened the lines now, so if you don't want to talk, please put your phone on mute. And if you are interested in sharing a little bit about the work you're doing, you could, what would help me is if you use a little hand, you can wave that hand, and then I can sort of make sure that we're not all talking at once. Oh, no hands waving yet, but it would be really interesting to hear other work that's going on, because I know there's a lot of amazing work going on around the country to keep folks aging in their homes. I guess everybody's getting shy. I'll give folks another few seconds, questions are still welcome, and if folks are feeling shy, we can always end 5 minutes early, no shame there. Well, I think unless there are more questions or folks want to share something, I think we'll end 4 minutes early. Well, actually, first I really want to thank Leah and Tricia and Eileen for sharing the work that you're doing, which is just phenomenal. Really excited. Folks, if you are thinking about applying for the HUD-assisted, the NOFA that's out, it would be fantastic to let myself, Sarah, or your relationship manager or health champion know, just so we have a sense of who's interested in this. It would be really helpful. And we will send out slides and information related to all the stuff you've heard today. But thank you again to the folks who joined the line, and thanks to our wonderful presenters. Have a wonderful afternoon.